Hi, this week we're talking about prescription drug abuse. And when we're assessing our patients, there are many findings that could indicate substance abuse. In these, there are physical, verbal, nonverbal, psychosocial, and even behavioral signs that we can pick up on when we're assessing our patients. And some of these are cognitive changes where they have an inability to think logically. We will oftentimes see a slow respiratory rate, heavy sweating. They'll wear long sleeves to hide track marks. And it's not just heroin. Some of the patients will even crush up PO medications, pain medications, and inject those. And oftentimes patients will have hypertension. They'll have very small pupils. They'll have problems with balance and stumbling around. They'll have, you'll see lots of bruises on their lower extremities, their arms. And when you ask about it, they're accident prone. They have lots of injuries from bumping into things or falling. They complain of exhaustion. It's to the point of they're in and out of consciousness. Distraction, unable to think about their daily activities of just normal life. They get focused and talking about obtaining drugs, and that seems to be their only focus in life. They have trouble even holding down jobs, going to school, maintaining their personal relationships and family lives. Oftentimes they'll have legal problems, whether it's traffic violations, breaking and entering, light theft, just stealing from families. They have relationship problems. They will oftentimes complain of generalized aches and pains, stomach cramps, diarrhea, fever. They have depression, anxiety. They're easily frustrated. And pathology of some of these changes are there's physiological effects are mediated through 4 different opiate receptors in the central nervous system and the periphery. And these receptors affect the mitosis or the pupil dilation or restriction. And they also affect the respiratory depression and mood changes, balance problems, sedation, as well as given the analgesic effects that oftentimes are the original reason that they even started taking these medications. You'll oftentimes, the hypovolemia due to the sweating and the poor PO intake and the temperature changes that they experience, all this leads to the hypotension that you will find whenever you're doing your assessments. And there are things that physicians, all healthcare providers are doing to try to eliminate some of this abuse of drugs and also the diversion of these prescription medications. And since 2005, the American Medical Association has supported and helped secure passage of the National All-Schedule Prescription Electronic Reporting Act, which is also known as NASPER, N-A-S-P-E-R. This is a tool to combat prescription drug abuse and diversion. And there has been an increased sense of urgency for combating diversion and drug abuse while preserving access to medically treating these patients that experience chronic pain. There are state-based resources that support identification and assessment of state-based addiction treatment gaps and funds while simultaneously decreasing access to diverted drugs. Point-of-care up-to-date prescription monitoring systems integrated into the physician's workflow. And what this does is help track prescriptions that have been filled by patients throughout the state or even nationally. And by putting in the patient's name and their date of birth, this helps eliminate the doctor shopping that a lot of patients do, where they go around and collect prescriptions, whether it's for their own use or a lot of these patients are selling their drugs on the street. It's a way of income for them. There's also federal funding for state levels, what they call take-back programs for removing used prescriptions from medicine cabinets. And the hope is that this could help eliminate, especially a lot of the adolescents, from experimenting with these prescription drugs that they find in their home from their parents or their grandparents, because adolescents are the fastest growing population right now of prescription drug abuse. And there are positive incentives to promote physician education for current best prescribing practices for physician practice and for the patient population needs. This is assuring that patients are still receiving pain control while the physicians are using best practice to closely monitor and titrate the use of these medications. And there is enforcement actions to halt what they call pill mills, which are these rogue online prescription pharmacies, and also funding for addiction to prevent those patients that are addicted to pain medications from progressing to illegal drugs, such as heroin. And heroin use is on the rise in the United States, as many addicts are finding that it's easier to get the illegal drug with the same or greater effect that the prescribed medications that they're getting, the pain medications they're getting off the street, or either prescriptions from the physicians. They're finding they can get that same effect or a stronger effect from the heroin use. And turning these addicted patients away without prescriptions is not enough, because we need to get funding for addiction and rehab needs in order to assist these patients to recover from their addictions so that they don't progress to heroin use. And many times we have patients that are labeled as drug seekers that come through the ER, as well as inpatient for chronic pain and chest pain. And first, if I suspect that they're possibly just seeking drugs, I will do a full physical assessment, including getting a background history on them, leading into the questions of use of tobacco and alcohol, and then to illegal drugs. Do an assessment on them for depression. I'll look through our medical records at the hospital to see if there's been a lot of recent either admits to the hospital or ER visits for frequent injuries that doesn't really go along with what they're saying happened, and from frequent complaints or similar complaints of pain. Then I lead into talking to them about if they have any relationship problems. Are they working full time? Do they have any issues with their job, with school? And you can tell a lot about a patient when you start finding out these things. And then if I still suspect that there is abuse or diversion, I go and talk to the healthcare provider, the doctor or the practitioner, about my concerns. And usually together, myself and the healthcare provider will go in and personally speak and confront the patient about our concerns. And it works out really well if you have a physician or a practitioner with you that is empathetic and wants to help this patient get assistance for their addiction, and not just say, I'm not giving you any pain medication and just letting the patient leave, but to try to talk to them and help them find the resources they need. And sometimes we're able to get the patient to talk about it, and lots of times we'll get the behavioral health intake nurse to come in and talk to them about community resources or inpatient treatments. Although we don't do it at our facility, if they're wanting inpatient treatments, they try to help them get in somewhere for the help they need after they are medically cleared at our facility. And sometimes the patients are receptive, and whether they follow through with it, we do give them the information, we give them education, on addiction. But sometimes we have patients that just get angry or even belligerent, and they leave the hospital against medical advice. And more times than not, that's what will happen. But we do try to educate them on addiction and explain to them why we can't just prescribe the medications to them and try to get them the help that they need.